Okay, everyone. Thank you, and welcome to our last session in our age-friendly geriatrics education Tele series on mental health. Thank you for sticking with us since January. Again, this is our sixth and last session from this series. And today's session will be focusing on mental health and what matters most to your patients. And will be led by our wonderful nurse practitioner in our hub team, Camille Fitzpatrick, and the rest of our hub team as well. So let's go ahead and get started. As you all know, this series is accredited by the ACCME, and this session is about 1 hour and will be available for 1 CME credit. The California Board of Registered Nursing does also recognize CME credits as transferable for their members, and nurses may receive CEUs after submitting their UCI attendance certificate. You should be receiving the certificate via email, the email that you provided when you registered for the series, so be looking out for that in the coming days. Today's objectives are going to be discussing the 4Ms framework and what matters most to your patients, reviewing touch points for what matters most conversations, and to discuss cases involving those what matters most discussions. I moved this to the beginning of the presentation because I just want to remind you all, if you do want CME credits, make sure you fill out the survey that is usually sent after each session. And then we always really do appreciate your evaluations as we use your comments and suggestions to plan future series. Recordings will be available for CME credits, and those links will be sent out in the coming days. So if you did ever end up missing a session from this current series, please feel free to watch out for that recording, and you can take the quiz and receive credits as well for those. Today's agenda are as follows, with welcome, announcements, reminders, and introductions to start off, and then moving into our didactic presentation and discussion on what matters most, and then our patient stories. And as a reminder, this session is going to be much more discussion-based, and we are relying on you all to participate in our polls, our questions, and to share your stories about best practices on how you incorporate those kind of what matters most discussions with your patients in healthcare settings. Our upcoming series, since this is our last session from this current series, is going to be starting on May 28th, same day and time, which is Fridays at noon Pacific Standard Time. And we'll be focusing on chronic conditions in older adults. And some of the topics we plan to cover are COPD, osteoporosis, hypertension, diabetes, osteoarthritis, amongst a few other things. So we will be focusing on why and how these things are different in older adults and how to treat those conditions. This is the sign-up link if you're interested in already signing up, but we'll be sure to send reminders as that series nears. So we hope you'll join us in May, and then you'll also spread the word to your colleagues. Back to this, so the house rules, make sure you mute yourself when you're not speaking to prevent background noise. Always introduce yourself prior to speaking with your name and location. Always maintain confidentiality. Since we will be discussing or having you share your stories, please be sure that you do not include any kind of personal health information about your patients and are respectful of the HIPAA. This session is being recorded, and your participation confirms your consent to this recording. And we are grant funded, and any information or content and conclusions are those of the author and should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. We do not have any financial disclosures at this time. And then we're going to go ahead and move on into introductions. If you would like to speak up today, or just type it in the chat, please do introduce yourself with your name, role, site, and location. And we'll go ahead and have our hub team introduce themselves today. My name is Nika Seville. I'm the project manager of our Geriatric Workforce Enhancement Program at UC Irvine Health, and we're located in Orange County, California. I'll go ahead and have Camille go ahead and introduce herself.
Hello, everybody, and welcome back. My name is Camille Fitzpatrick, and I'm a geriatric nurse practitioner and clinical faculty of the School of Nursing at UC Irvine. And our practice is at the Santa Ana Family Health Care Center, where we teach our residents and nurse practitioners. So welcome today.
Thank you, Camille. And Dr. Sagel?
Hey everybody, I'm Sonia Sagel. I'm a professor in the Department of Internal Medicine, the Division of Geriatrics and Gerontology, and my practice site is in Orange. It's located at the UCI Senior Health Center.
Dr. Gurvich.
Hi, I'm Tanya Gurvich. I teach geriatric pharmacology at USC School of Pharmacy, and my practice site is at UCI Medical Center at the Senior Health Center, where I help providers take care of older patients.
And Carlos.
Happy Friday, everyone. My name is Carlos Garcia, and I'm the web data analyst and for UC Irvine Health here in Orange.
Thank you, Carlos. And Dr. Gibbs will be joining us in a few minutes. Is there anybody on the line who would like to introduce themselves? I know we have some coming through in the chat, but you're more than welcome to also speak up if you'd like. Okay, it looks like we have Beatrice Videz, we have Laura Langley, and we have Chantiel, Carolyn Ray, Linda King. Thank you all for introducing yourself via chat. Dr. Hubi, Dr. Chen, thank you all so much for joining us today. Let's go ahead and move on into our didactics. So Camille, I'll leave it to you.
Okay, thank you. Well, thank you everybody again for attending our last session today. And if you were with us last time, you know that I always begin my lectures or presentations with a quote. And today's quote is from the Dalai Lama. When you talk, you are only repeating what you already know. But if you listen, you may learn something new. So today we are going to talk about stories and what matters most to us. Stories are really one of the best way to learn and remember things. And so since we all have patients whose stories have taught us about what matters most, this is a group presentation of sharing those stories. So what matters most, next slide, please. What matters most, this is the Age-Friendly Health Systems Initiative, which builds from the Institute for the Healthcare Improvement previous work in shared decision making. It expands the asking of what matters beyond the context of end-of-life care to all care with older adults across their lifespan. So as we've been talking about these last 5 weeks, the 4 M's, these are evidence-based elements of care for older adults. What matters, which we'll talk about today, medications, which we've talked about throughout, mobility, how our patients actually get around, how do they move? Mentation is dementia, depression, delirium, and this is across all settings of care. And of course, what matters most. Next slide, please. So where can we have conversations about what matters most? Where do these conversations happen? We don't want to leave them until the end of life, certainly. So across our continuum of taking care of our patients. So the first one that comes to my mind is during our regular visits and our annual wellness visits. The annual wellness visit, the Medicare annual wellness visit, is an excellent time to talk to patients about what matters to them. The conversation can start there and then continue. Actually, during our Medicare annual wellness visit that we do, one of the questions we ask, rather than just what matters most, is what might you change if you could? What is important to you? And of course, there's many different answers depending on how healthy the patient is. So it may just be like, I just want to see my grandkids, or it might be, I wish I didn't have diabetes, or I want to get back to driving. But it's just a good time to discuss what is important, what matters most to the patient. Another time that we could discuss what matters most would be during a new diagnosis or a change in health status. So you could schedule an initial what matters conversation a week before the patient has gotten a new diagnosis or a change in health status. So it wouldn't necessarily be, although it could be, with a new cancer diagnosis. It could be with a new diabetes diagnosis or a new change of medication. Anytime there's a change in diagnosis or a change in health status, it's a good time to ask them what matters most to you. Another time that you might have a conversation with your patient is just during a primary care appointment. So if they've just entered retirement or they've enrolled in the Medicare initial visit, you could have a conversation about what matters to them, how this change of life stage, how it changes for them. Another time would be chronic disease management, again, during the primary care visit, as their goals are changing or you're updating the medication, that might be a time to just have a conversation with them. And then finally, during any of the inpatient visits, hospital, nursing home, skilled nursing facility, it's important to ask them what matters most and then document any new information. Next slide, please. So these might be some questions to consider for discussion. What's important to you today? What brings you joy? What makes you happy? What makes your life worth living? Is there something you're worried about? What would make tomorrow a really great day for you? What else would you like us to know about you? Or an important aspect is, how do you learn best? So do they learn by reading or listening or perhaps watching a video? Next slide, please. Further questions about anchoring treatment in their goals and preferences is, what is the one thing about your healthcare you most want to focus on so that we can do whatever it is more easily? We all have had patients where we have one idea of how the visit's going and they have another idea. So it would make life a lot easier for both of us is if we address that at the beginning. What are your most important goals now? How do you think that might change? What are your fears or concerns for your family? If we have a patient who is the caregiver of someone with dementia, important conversations might be, what would happen to your family member if something happened to you? Is that something you'd like to discuss? And so again, having conversations of what matters to them. And then finally, an important question might be, is there anyone who should be part of this conversation with us? Next slide, please. So my first story is a 90-year-old male. He's healthy-ish, lots of medical problems, but independent. He lives independently with his daughter, but his daughter, who is in her 50s, has mental health issues. So he is really the healthy one, so to speak. He's a very, very active man, drives, of course, even though he has pretty severe macular degeneration. He was in the Marine Corps band, but he continues to play his trombone every day. He loves his trombone. Prior to COVID, and again now, though that he's been vaccinated, he played in 4 different bands, including going to nursing homes. He played his trombone with various bands at colleges around. So this is a very active, independent man. He does have multiple medical conditions. As I said, he had macular degeneration. He has CLL. And it's under treatment, and periodically his platelets get incredibly low, but then he'll have platelet transfusion and he bounces back. He has atrial fib, he has pretty labile hypertension, and he's on lots of medicines to try and get that under control. But he is active and nobody can put him down. However, in November of 2020, somehow he sustained a subdural hematoma, and it was successfully drained. He went back to going about his activity. He did have to stop playing his trombone, though, for a period of weeks. So he receives his care in Boston, but he lives about an hour away. Okay, so this is a very active guy, somebody you can't put down. In the middle of the night in January one night, he has bad chest pain. So he awakens his daughter with the mental health issues, and she calls 911. He goes off to the emergency room. She goes back to bed, doesn't call anybody in the family. So nobody else in the family knows that he's been taken off to the hospital. So the next morning, his daughter, who is his healthcare proxy, receives a call from her dad. And this is her story. When I received a call from my 90-year-old dad from the ER of our local hospital, my heart sank. My dad told me that he was rushed by ambulance for chest pains and was told by the ER that he had suffered a heart attack. I was panicked, anxious, and felt helpless, knowing that I was unable to be there with him due to COVID visiting rules. He sounded tired, worried, and couldn't provide me with any details. I had many questions. I asked him to please tell the doctor to call me, and he said he did. I am his healthcare proxy, and my family began contacting me for details that I didn't have. I was so scared and concerned, so I reached out by phone to the ER. The nurse I spoke with assured me that the doctor and or his team would call me. The call never came. I reached out to my dad's cardiologist, knowing he is not affiliated with that hospital, but my dad is in. I was in a panic on whether we should move him to the hospital in Boston, where he had been treated previously, and they know the severity of his conditions. The cardiologist's office contacted the ER where my dad was and spoke to the ER doctor immediately. He was able to get the full diagnosis and test results to understand what was going on. My dad's cardiologist contacted me and explained in detail what had happened. He told me he specifically had asked the ER doctor to call me and assured me that I would get a call from them. The call never came. 3 times they were asked to call me and the call never came. Is it because he's 90? I'm asking myself. Certainly, it can't be that they are too busy to communicate with the family. I was frustrated, angry, and mortified that I was ignored. I found it totally unacceptable. And I wonder how the doctor would feel if it were his 90-year-old dad sitting in an ER room and could not find out whether he would live or die. So I'd like to stop here and ask for any feedback. How did this make you feel? Has this happened to you? Any comments about this at all? Just unmute yourselves.
Camille, yes. Both my parents had strokes within 6 weeks of each other in the fall. And the communication was absolutely atrocious. And even knowing I was a healthcare provider, it didn't make it any better. You know, it was so horrible because they were in Northern California and sometimes I couldn't get up there because I was teaching. And to have to call into the ICU and feel like I was bothering them and to be told I would get a call, and then I'd call back an hour later. And then they were more irritated because I'd keep calling. You know, it was horrible. So I've been there and it happened not once, but twice, because both my parents had strokes within such a short period of time. And so, yeah, it is that feeling of helplessness. You feel utterly helpless. And then, you know, they can't speak or advocate for themselves. So you're not there to advocate for them. What kind of care are they getting? Mm-hmm. What kind of care are they getting?
Right.
It's scary. absolutely scary.
Thank you, Sarah. That's horrific. And your parents now, are they home?
They're both alive and, you know, able to tell the tale, but just that feeling like you're bugging people when all you're trying to do is to get, you know, to get any kind of communication going. The fact that that we weren't being proactively sought after, rather than me having to try and call multiple times to get any kind of word about what was going on. We weren't called with updates. So when they were moved from unit to unit, we weren't told. They were like, oh, they've been moved. And there'd been status changes. We weren't called. So to be having to chase down information. And then when you did call, to be made felt like you were, you know, putting them out. That was, I think, part of the worst feeling, you know, like you were bugging them. So then you didn't want to call. And I'm a nurse practitioner. I've been a nurse for 21 years. I mean, you know, it's just, so it got to the point where I escalated it up to the charge nurse. And then, you know, and then I thought, this is a big quality improvement project. There's some kind of protocol where nurses are required to call families, almost like vital signs, every 4 hours and give a status update. There should be some kind of protocol or QI project going on, you know?
Right. That's actually, that's very good. I like that. All right, thank you. Anybody else have anything to offer?
Camille, I wanted to just make a comment. Actually, this is Sonia Sagel from UCI. You know, it's interesting. I don't have a remedy, unfortunately, but I have an observation. My husband is pediatric oncology and works at a local hospital. And I find, from my view, which is not in the hospital, but I find that the staff and the providers who care for pediatric patients seem to be much more patient focused. They will round. They don't, you know, all round at 8 o'clock in the morning or at 10 o'clock in the morning. They round when they know the patient's families will be there. Mm-hmm. They respect that these families, these parents work and have jobs that they need to get to, and will scale and communication around that so that the families are informed at multiple time points. And that's just how my observation is that's just how they operate. And it kind of goes back to, you know, and I'm an internist, so I'm opposite end of the spectrum. I remember rounding inpatient and, you know, we draw blood at 3 a.m. because it's convenient for us, not necessarily best for the patient. Whereas in pediatrics, if the baby or the child, if they're sleeping or the parent's sleeping because they need their rest, they'll wait and come back and do the blood later. Mm-hmm. So I wonder, you know, in terms of our perspectives in adult care, if something needs to change.
Right. And to go back to the daughter's perspective, is it because he's 90? Is it Sarah, your parents were older, I would take it. Is it we don't treat our older adults with the way they should be, and we treat children differently? Don't know. Just points for thought.
And we have Laura in the chat who says it happens much more often than family members would like for it to. It's a horrible and scary feeling. Shame on the hospital staff for not being patient advocates.
So a quality improvement program, yes, maybe. Should we do our second story?
Sure.
Okay. Second story is a newly retired man with diabetes. He's 68. He's been managing his type 2 diabetes and moderate hypertension for the last 2 years. He's getting ready to retire and he wants to spend more time gardening, traveling around the country in an RV with his wife. His PCPs prescribed multiple meds to control his blood pressure as well as regular appointments to monitor his blood glucose, which has been difficult to get in control despite dietary changes. Sounds like many of our patients. At his Medicare annual wellness visit, the PCP asks about goals and preferences around his retirement. He's nervous about bringing it up, but mentions that he often feels lightheaded from the hypertension medication and as a result is not able to garden as much each day as he would like. He also mentions that the weekly doctor's appointments his doctor has requested will affect his ability to go on longer trips. He's retired now and he wants to travel. It's important to him that his diabetes and hypertension are well managed, but he worries that this management is making his life less enjoyable. So what might be the next step at this point for his care? What matters most to him? Any feedback?
This is Beatrice from UCI. Maybe now with the increased use of telemedicine, maybe this might be an option or an opportunity to discuss with the patient, maybe doing some of his visits, doctor visits by phone or by video to alleviate some of the burden of him having to come into the office, and he can take the call or he can take the video call from his family's home.
Great idea. And it's paid for, right? Medicare pays for it.
Right.
Right. Good suggestion. Anybody else? Okay. So, Nika, did you want to do the polls now, or yes?
Yeah, we can do the polls. So we have 2 poll questions, and it's going to come up on Zoom. So hopefully, if you can't do the poll, then you can either type your answer in the chat as well. But our next question is, do you include what matters most types of discussions in your practice with your patients? And it's really just a yes or no question. So it should pop up right now for you. You should be able to click on yes or no. Okay, we have quite a lot of votes coming. About 86% say yes so far, 14% say no. Okay, it looks like 12 votes for yes, 2 votes for no. Okay, so we can end that poll. So let's see, it looks like, okay, 86% of you said yes. Is anyone willing to share or talk about how you incorporate what matters most into your practice with your patients? You can either type it in or go ahead and speak up and share how you include that in your practice. And of course, Bernie Milbury says probably not directly as matters most, but it's covered, but the conversation is covered. And that's totally fine. It doesn't have to be a specific question that you have, as long as it's covered somehow. Discuss how life is going, what has changed. That's what Bernie is mentioning in the chat right now. Anyone else want to talk about how they incorporate these kinds of conversations in their practice? I know 86% of you said yes.
I'm curious to know, for those who said no, if there was a reason why. I can imagine that.
Yeah,
Oh, sorry, go ahead, Nika.
I was going to say, I know we've read that it can be definitely tough to incorporate these questions because of time, or in inpatient or emergency settings as well. It's pretty hard to include these types of conversations. And so we'd love to know, yes, if you can't include them or haven't, what's the barrier been? And Dr. Sagal, I know you were about to say something.
No, I was just about to say the time issue. I know I know many people are on a very tight schedule and need to see patients kind of in a rapid fire fashion. So I can imagine that is a barrier.
I'm also wondering if people ask the question and they don't know what to do with the information. That might be something.
This is Beatrice from UCI. In a research setting, it's a little bit different with the what matters most question. So for us, really the goal is to try to keep patients enrolled in the study, especially when they're very lengthy, 3, 4, 5 years. So what I've always incorporated is just getting to know them. We have the luxury of time because many of our visits are very long. So we have the time to sit down and chat about their family, their health, things that will make them feel human, not just like a number in a research study. So we're blessed with the beauty of time in our setting. But that has always felt to me like a very powerful retention tool, but also it's something that I find pleasure in doing, is getting to know the individual. And even patients have said that the clinical team becomes more like their friends rather than the doctor or the nurse practitioner seeing them.
I couldn't agree with you more, Beatrice. When I was in training, I trained, we had paper charts back then. And one of my attendings in the top corner of the progress note would write things like what their child's name was, what their hobby was, what their dog's name was, so that the next time they met, it would jog the memory of the provider, of the practitioner. And for me personally in geriatrics, one thing we talk about in healthcare overall is burnout, and how prevalent burnout is. But one thing I find that rejuvenates me in healthcare and in my practice is really knowing my patients, knowing what they're doing, where they went on vacation, what their garden looks like, who is a cook, or what they do. I mean, that's really the joy of knowing of my patients, and really the joy of a continuity practice, I think. So, and it helps to really get to what matters most to patients.
Right.
And we have Laura Langley in the chat who says, quality of life is important to most elderly patients. I ask about their goals in life and go from that angle. And I know, at UCI, our inpatient and emergency departments are working on becoming age-friendly through the IHI designation. And I from talking to our inpatient unit, I know that they incorporate this question. They say, they ask their patient, what is your goal for this hospitalization? And they kind of write that on the whiteboard that's in the patient's emergency room. And then in our ED, they ask them, what would they like to see from this specific visit? And they map that out as well.
I wonder if I might share a patient story, if this would be an okay time to do that.
Mm-hmm.
Just very briefly. So in November, December of 2020, so in the height of the pandemic, I had a visit with a very long-time patient of mine. This was an 80-year-old gentleman who has diabetes and high blood pressure and atrial fibrillation. And he had been very cautious the entire pandemic, would wear a mask, had stopped going to the grocery store, was having everything delivered to his home, really did a fantastic job staying safe and keeping everyone around him safe. But he called me because he was worried about an adult disabled son who lived in Phoenix and was having some personal difficulties and needed to move residence. So the son was living in an apartment and needed to make a move to a different place to live. And the son wasn't able to do that independently. He would need some support. And my patient had the financial resources to hire someone to do that, or to get someone in the local Phoenix area to assist. But he felt that as a father, he wanted to be there for his son and to be able to assist in his life during this time. And he was contemplating flying to Phoenix to be with his son for 3 or 4 days to make this life change. And we talked about the pros and cons, and I was very worried for him because, here we are, the coronavirus numbers are sky high. He's going to an area where cases are out of control. And he's elderly with significant risk factors. And I was uncomfortable for him, should he acquire COVID, a very high mortality risk for him. I was uncomfortable. He was not. And he said, I've lived a good life and I accept the risk of acquiring this infection, and whatever happened to me, happened to me, but I need to be there for my son who, in this moment needs me and has a disability. And he did fly. So I was very uncomfortable. But we talked about precautions, and I trust that he was as safe as he could possibly be. And he went to Phoenix and did assist his son, but when he came back 2 days later, developed symptoms of COVID, tested positive, and was ill for a while. But in my conversations with him as he returned, he had no regret, no remorse. He felt that he had done his fatherly duty to be there for his child, even if that meant risking his own life. And it really, showed me, that this is, obviously what matters most to this person. He risked his own life for the success of his child, and he had he had zero concern about it. It was me as a provider left, gosh, like, is he going to be okay? Very, very stressful for me, kind of as a bystander watching this.
Right.
So I just wanted to share that story.
Thank you, Dr. Sagel. And that kind of leads us into our next question, unless anybody else wants to answer this question before we move to the next one. Okay. Our next question is, have you ever been in conflict with the patient's decision plans? And so if we can put that poll out there, and that it's a yes or no question, please answer. Okay, so far we have about 71% that have said yes, 29% saying no. Okay, and I think that's the result. So 71% yes, 29% saying no. So if yes, can you share the situation or how it was resolved? Anyone want to share?
I'll share if no one else has any comments. So in terms of, I mean, just speaking about the patient that I just shared, who acquired COVID, I was worried for him, but I try to put myself in his situation and understand his emotion as a parent. And I tried to educate and advocate for him as best I could, and promised to be there for him, when he returned, and saw him through his COVID illness with no judgment. And thankfully he recovered from his infection. So feel very fortunate about that. And actually, even though I was not a fan of him, flying to Phoenix and doing this, simply because it could have been done by someone else who was local to his child, I did think back on our relationship, on the patient-doctor relationship that we had. And I recalled a time about 3 years prior when the patient had newly been diagnosed with atrial fibrillation. And he had been diagnosed with atrial fibrillation, but was pending an appointment with cardiology and had not started anticoagulation yet. He was still in the workup. And he had planned a lifelong trip to go to Norway. And he wanted to explore the backwater channels of Norway that are not often visited by tourists. And he had booked himself on a freight ship that carried freight, to these remote parts of Norway, and got himself a room on one of these freighters and planned to do that. There was no medical care on these ships. This was not a luxury liner. It's a working ship. And he was like 77 at the time. And we again had a conversation about, hey, like, you have atrial fibrillation, you're not anticoagulated, we can start it today, but you might have a stroke. I don't know, your heart situation has not been resolved. And he chose to go. And these weren't decisions that he was making irrationally. He's he's an educated man. He was very rational, but he knew that his health, in his eyes, his health was one facet of his life, and that there were other parts of his life that were very important that he wanted to fulfill while he was alive. And so again, another situation where I was left really worried for him, But he went on this trip, and thankfully he returned and was able to see the cardiologist and get on treatment.
Thank you for sharing, Dr. Sagel. Would anyone else like to share?
It's Beatrice again from UCI. I actually recently had a conflict with a patient about COVID. We unfortunately had a potential exposure in our research center, and we had to inform patients about, quarantining. And unfortunately, it happened right before Christmas. So the patients that were in contact with this person had to quarantine during the Christmas holiday. So needless to say, we had a lot of upset patients. And we had one particular patient that was incredibly upset because in his mind, he felt that we were not doing enough to protect him, that we should have done more, like offer vaccination, offer testing. And, he had a lot of expectations of the team that we just could not meet. And no matter how much I tried to reassure him that our practices follow UCI health guidelines, CDC guidelines, he just was not willing to accept that we were practicing with his safety as in our interest. And unfortunately, he decided to quit his participation in the study because we could not provide him what he wanted. So that was a different type of conflict, but it was what's the word I'm trying to say? I just felt like there wasn't enough that I, could I have done something else? Not really. Our hands are, there's only so much that we can do as researchers, and we followed every rule that we possibly could. But there was no changing this gentleman's mind, and unfortunately, we lost his participation.
Thank you for sharing, Beatrice.
Sure.
Okay. Camille, anything else from this question?
No, I think we're set, and potentially, it would be nice if everybody here has any stories that they might like to share about, what you considered most to them and their care plan, and how it turned out. If anybody has any other stories, we'd love to hear.
I'll share a story, Camille.
Thanks, Sarah.
So this is a story from my previous practice. I was in an internal medicine practice, and we had a patient who her daughters had recently moved her from out of state to come live with them in the area locally. She was 88 when she came into my practice, and she had pretty advanced dementia. And so they wanted her close by, and they had put her into, actually one of them had brought her into their home. But they were trying, so we were establishing care, and we were, kind of getting all of our ducks in a row with her. And she was very pleasantly demented. She was very sweet and actually quite funny, very humorous. And we had a lot of fun with her, but they were trying really hard to convince her to get a flu vaccine because she moved right in the middle of flu season. And, they were concerned about, because they would take her during the day to a care center during the day and try and get her, some socialization. And they were worried about her getting flu. And she did not want it. So they solicited my help in trying to convince her to get flu. And we were just establishing our relationship. And so, of course, I tried to talk to her. I talked to her about the, why it would be beneficial. And, this went on for several visits. And finally, I began to realize that, what matters most to her is not getting shots. She does not like shots, because I started to explore, was it really the flu vaccine? Was it the shot? What is at the heart of why she doesn't want to get the flu vaccine? Mm-hmm. And so she finally said to me, I hate shots. I hate needle. And we just had a fun conversation about where it stemmed from and her perspective on it. And so I just said, you know what? That's fine. We're not going to give you any shots. And I looked at her daughters and I said, no shots for her. And I began to advocate for her and really kind of just let her be the captain of the ship. And even when it came to decisions, I really looked to her to ask her her opinion. I let her be the one that made the decisions, even, in things that we did day to day, in her care as we made decisions. And what was really funny is we started making a joke out of it. So she would come into the office and I would say, I've got a shot for you. And I'd hold up a needle and she'd look at me and she'd start laughing. And then the next time she'd come in and she'd go, "You're not going to give me a shot, are you?" And she would joke about it. And this became our ongoing joke. And it got to the point to where she couldn't remember what she ate for lunch, but she remembered this joke between us. I mean, she had really advanced Alzheimer's, and she and I became such good friends. And they said, from then on, she became really compliant with kind of our care plan. She was involved. She really enjoyed the decision-making process, and she might not remember that she helped made those decisions about her care, but she really enjoyed it. And just that ongoing joke. And she would say it before I even did. She'd come in the hallway and go, "I'm ready for my shot." And it was just a fun joke that we just, had back and forth. She was just lovely. And she was about 4'10" and just adorable and such a lovely lady. But they said they've never seen her interact with a care provider like that, and never seen her be so involved and so invested in her care plan like she was. And granted, she would forget that she made those decisions, but when she came in, she was ready to talk and ready to be involved in the decisions we were going to make. And it was just a really neat turn of events. And her daughters, in kind, began to follow suit. They stopped dictating and they began to kind of follow my lead and ask her opinion, where before they were just kind of pushing their agenda on her. So it was great. We had a good time with that, and she was just lovely.
What a great story. Thank you, Sarah. That's a good story. Anybody else?
That is a good one.
That's a good
Thank you for
story.
sharing.
Anybody else have another story?
We can move on to the next slide. We don't have
Okay.
that much time. Let's move on to the next one. Thank you so much, Sarah Campbell, for sharing.
It was great. So, and kind of end for our last couple of minutes, people don't always need advice. Sometimes all they really need is a hand to hold, an ear to listen, and a heart to understand them. So, thank you.
We wanted to end the session with a quick video. So let me go ahead and play this for you all. 1 second, please. Okay.
Doctors and hospitals really aren't what we call conversation ready, because we ourselves have so medicalized everything that I'm seeing for this patient. What's the dose of this medicine? What's the chemotherapy or not? With this test or not? That we ourselves don't actually often have the experience, the practice, the support that we need to sit down with the patient as a human being, understand what's important to them as a human being, and make sure that that's always at the center of every medical plan. I was asked to see Thelma Patella. All that I knew was she was a 92-year-old woman who had severe vascular circulation problems in her leg, causing her lots of problems, for which there wasn't going to be any effective treatment that they could offer except amputation, which she just refused. She wasn't going to have that done. And so they said she didn't have that long to live, and so they wanted me to come by and maybe talk to her about hospice kind of options.
What I remember, I guess, most strikingly was that Dr. Farrow asked her, what would be a good day for you?
And so I sat down on the bed. I said, getting to know you some as a person will help me figure out how I can best help you.
And it's such a simple question. What would be a good day for you? What do you like to do? These things that I don't feel like I have time, honestly, on a daily basis when I'm seeing patients, when I'm on call, to ask these little things.
In whatever time there is ahead for you, how can we make that as good as it possibly can be for you. Singing is what made it a good day.
But it didn't take that long to find out that this is what was important to her.
I said, when was the last time that you sang? And she just sort of said, I haven't sung in a long time. I don't sing anymore. I said, why not? And she kind of looked at me and said, how about singing me a song?
I see trees of green, red roses too. I see them bloom for me and for you. And I say to myself, what do you say, darling? What a wonderful world. Somebody, where's the drummer?
I see skies of blue.
I see skies of blue,
Clouds of black.
clouds of pink,
The bright,
the
blessed
bright,
days.
blessed sun, and the dark, sacred night. And I think to myself, what a wonderful world. And I think to myself, what a wonderful world. Pop, 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 pop. Oh, yeah.
And it made such a huge difference in her day.
The music was right there as vividly as it had ever been. And every time her voice started to sing, you could just see her eyes getting younger, her face getting younger, and the kind of human joy returning.
Thank you guys for being with us. Does anybody have any closing comments about that video or any questions?
Made me cry. It's a great way to end this on a positive note. Thank you for that.
Yes, of course. Thank you all for joining us today and for the whole series. I'll be sending up a few resources, and some of them are linked to this presentation as well, which we will be sure to share. And we will make sure to also communicate with you about our next upcoming series coming in May on chronic conditions, so that if you would like to register now, you're more than welcome to. And again, thank you all to our hub team and to all of you folks for joining our past series and this one. And again, we'll hope to see you in May. Thank you so much. And thank you all for sharing your stories with us today.
Thank you, everybody.
Thank you, everyone.